See you again. Today, we are going to learn about subcutaneous infusion. We all nurses, we all are familiar with subcutaneous injections, not with subcutaneous infusion. This is one of the major topic in palliative care. Most of the patients will be receiving fluid with the subcutaneous route. And also the end of life care situation, they are not able to swallow properly. So that time we don't get good vein for intravenous infusion. That time we suggest subcutaneous infusion. So this session will be taken by Mr. Sajan, who is a senior palliative care nurse. He has 10 years of experience in palliative care. So he took one session for us that is on ostomy care. Today, subcutaneous infusion. Welcome back, Sajan, and over to you.
Once again, good evening to all. I'm Sajan Vias. Today, I would like to introduce another topic, subcutaneous infusion. What do you mean by subcutaneous infusion? Is having another term also for the subcutaneous infusion. Can anyone know about another term for the subcutaneous infusion? You can share in chat box also.
Recording progress.
If you know, means kindly message. Okay, I think we can move to the topic. Subcutaneous infusion. First of all, as a nurse, we are all having so many options are there as a part of the administration of the medication. We are having so many options as like route of administration. Parenteral and non-parenteral route of administration already we practicing. In parenteral nutrition, parenteral administration of medication means in our practice, mainly majority of you practicing which route? Can anyone answer? Which are all the routes mainly you are supposed to give an injection for a patient means which are all the routes commonly you are practicing? Okay, IV, IM, subQ. Okay, oral. Okay. As we know, we are having so many routes are there for the administration of the medication. In parental route means so many of you from you only answered as IV, subQ, IM, like that. So as in our practice, mainly we most of all preferring intravenous route and intramuscular route. Then subQ route also we preferring. Suppose some medications we need to give by subQ means we will give. Otherwise, commonly everyone practicing IV and IM route of administration. But in palliative care, if suppose one patient need to get on injection means, if it possible means, first of all we will choose the subcutaneous route. So the subcutaneous route have an important role in the palliative care, mainly in the palliative care. First, I am simply dividing the skin layers into three. Just simply divided into three. First layer, dermis. Second one is the subcutaneous layer. Third one is the muscle layer. We're going to discuss about the second most layer, subcutaneous layer. First, in first time I just asked another term for the subcutaneous infusion. Only one given answer as the term hypodermoclysis. What do you mean by hypodermoclysis or the subcutaneous infusion? Already I told hypodermoclysis is another term for the subcutaneous infusion. If suppose we just hearing about only the term hypodermoclysis means we will get the meaning from the term itself. Just split the word hypodermoclysis into three. Hypo first part, second part is the dermo, clysis is the third part. Hypo means below the level of dermis layer. Below the level of dermis layer, subcutaneous layer. Clysis means administration. So the definition of the subcutaneous infusion or the hypodermolysis we can define as the administration of small volume of medicines like bolus type of injection or large volume of medicines like infusions to the subcutaneous space is the definition for the subcutaneous infusion or the hypodermolysis. In already I told in palliative care what are the main importance of the subcutaneous route of administration in palliative care. First one, if suppose we seeing one patient with severe dehydration, if the dehydration level is mild to moderate dehydration case means for the rehydration purpose we can give the infusion by the subcu route. Then, if the patient having the swallowing difficulty and due to the swallowing difficulty, patient is unable to take oral, its oral intake very much reduced, or patient is unable to take anything by orally, means we can give the injections or the infusions by subcutaneously. Then third one, if suppose we planning to give fluid for a patient within 24 hours or within 1 day, 3 liter, maximum 3 liter of fluid if we planning to give on patient means we can give that fluid as like infusion by subcutaneously. In palliative care, majority of our patients may be cancer patients with having severe distressing symptoms also. First, if the patient is having the severe distress like nausea or vomiting, patient is having severe nausea. If the food content they are seeing means also, or that smell also provoking the patient about the nausea, or patient is having severe vomiting. Maybe the vomitus may contain the fecal matter also. That much bowel obstructed cases with severe nausea and vomiting means patient is unable to continue the oral type of medicines as like tablet form or syrup form of medicines. So that type of situations we can give the injections by subcutaneously. Then if the patient having the oral lesions or oral ulcers in the mouth and throat area, there is a lesion already the patient is having. Due to the lesion and ulcer formation, patient is having the pain and the swallowing difficulty also, painful swallowing also. Patient will refuse to take the medicines and will refuse to take the oral food also. Such situation also, the maintenance, we can give fluid or otherwise for the symptom management, medicines we can give the injection form by subcutaneously. Then majority of the cancer's condition related with the gastrointestinal system due to the progression of the disease or due to the primary situation, maybe the intestinal obstruction can occur at any time. Due to the intestinal obstruction will cause the nausea and vomiting, or otherwise the oral route of administration of medication is inappropriate in such situations. So in that time also we can give the injections by subcutaneously. Then unconscious patient. I'm not telling about the unconscious patient, mainly we seeing in the ICU setting. In palliative care setting, already the patient and family well known. We also well known about the patient condition. Now the stage of cancer condition we know. Prognosis is poor. Patient is deteriorating, going to the end of life stage. Now patient is becoming an unconscious level. For comforting the patient, we need to continue the mild doses of the symptomatic, symptom-free medicines we need to continue. Or otherwise, for maintenance of the quality of the life, we need to continue the fluid also. In such situation also, by subcutaneously, we can continue the medicines and the fluid. Then, if one patient having severe pain, example, some situation I'm telling, if the patient is having 10 by 10 pain or 9 by 10 pain, that much severe pain, patient is crying very much due to the severe pain. Such situation, if we choosing the tab type of morphine, 10 mg or 5 mg, suppose we giving, means, is it appropriate in such situation? Is totally inappropriate. That oral form of morphine is not suitable in such situation. So these type of severe pain situation means we can give the subcutaneously, we can inject the injection morphine. Or otherwise, in second situation, if the patient is having severe restlessness, patient is very much delirious, patient that means restlessness. That's it. Such situation also, by injection form of medicine, we can give to the patient and make rest the patient. Then, if one patient is taking oral form of morphine by for a time period, due to the swallowing difficulty or due to the deteriorating stage, suddenly the patient is becoming unable to take the oral form of medicine, then we can move to the rectal route. Same dose of morphine we can give by rectally also. Both are non-parental route only, oral and rectal. But in some situation, the rectal route is inappropriate, maybe in becoming inappropriate in such situation. Like if the patient is having rectal prolapse or rectal bleeding, or otherwise patient is having loose stool or spurious diarrhea, or the patient is totally refusing due to the shyness, then we can continue the rectal route for the administration of the medication. Such situation also we need to depend injection form of medicine for making comfort for the patient. Then we can give the injections by subcutaneously. Then we can move to the what are all the sites commonly we can give the subcutaneous injections. I'm asking this question to you. Can anyone share your ideas? Which are all the sites we can give the subcutaneous injections?
Onto the abdomen.
Okay.
Abdomen.
Okay, and abdomen, scapula. Any more? Thigh. Okay. Okay, thank you. So these are all the sites we can give the subcutaneous injections, mainly in the upper chest region. Upper chest region means intercostal plane or upper chest region. In upper chest region, if we giving the subcutaneous injection means, if suppose we choosing this area for a female patient means, be cautious about, don't involve in the breast tissues, or otherwise it will damage the breast tissues and it will cause the tissue damage. So first one, the upper chest, next one, upper arm. Upper arm in outer aspect of lateral aspect of outer arm, upper arm. In upper arm, if we measuring means 7.5 centimeter below the level from the shoulder region and 7.5 centimeter above from the knee level, elbow level. In this region is the lateral or outer aspect of the upper arm. Both upper arm, these aspect we can give the subcutaneous injection. Then abdomen. Abdomen means 2 centimeter around, 2 inches around the umbilical region, we can give the subcutaneous injection in the abdomen. In outer thigh region means here also lateral aspect of thigh or outer aspect of the thigh region, we can give the subcutaneous injection. Then upper back or outer quadrant of the buttocks region, upper back, we can give the subcutaneous injection. Then scapular region also. These are all the main regions we can give the subcutaneous injection. This is the diagrammatic representation. Upper chest, upper arm, abdomen, outer thigh, upper back, and the scapular area. These are all the common sites we can give the subcutaneous injection. But in our setting also, we commonly practicing in upper arm and upper arm outer aspect and lower arm outer thigh or lateral aspect of thigh region. These are the common region we practice in our setting, because in our setting, and you can also continue the subcutaneous infusion or some subcutaneous injection in their home setting also. Suppose the subcutaneous injection may will start or may need to continue in home setting, means we can educate the caregiver, and caregiver also may will feel more confident to give these type of subcutaneous injections in the outer and lateral aspect of upper arm and lateral aspect of thigh region. If it is not possible, means only we can move to the other sides like abdomen and the scapular region, upper back or upper chest. Then what are all the sides we cannot give the subcutaneous injection? Means first one, if the we choosing the upper arm, right upper arm we choosing for giving the subcutaneous injection or infusion. Already the that arm is affected with the lymphedema, means we cannot give the injection in that arm. Then already the skin side having any irradiated skin, any bony prominence is there, means we need to avoid. Then nearest to the joint region, means we need to avoid. Then already the selected site is very much skin folds already is having, means also we cannot completely identify the subcutaneous tissue. So that region also we need to avoid. Then already any infection or any inflammation sign is already they are having, means also we cannot prick that area, it will irritate. Then if the abdomen area is choosing for giving the injection, means already the patient is affected with ascites or any pitting edema, not only the lymphedema, pitting edema also they are having in lower extremity, or in abdomen means ascites, already the patient here having also, means we cannot give the injection and continue the infusion in abdomen or the lower extremities also. Then the most common in tumor site or in a scar tissue, means also we cannot give the injections or infusion by subcutaneously in these areas. Then these are all the some example for the medications we can give by subcutaneously. Studies are going on daily basis, proving some more medications we can give by subcutaneously. But in our practice also, commonly we practicing as like giving these type of injections in by subcutaneously. First one, injection morphine, haloperidol, midazolam, metoclopramide, fentanyl, iosine butyl bromide. These are all the common medicines we can give by subcutaneously. These are all the medicines, these type of medicines we cannot give by subcutaneously. Injection stemetil, diazepam, then chlorpromazine, any antibiotics or hypertonic solutions as like normal saline 3%, then or otherwise dextrose 5%, 25D, that type of hypertonic solutions or antibiotics or these type of injections we cannot give by subcutaneously. If suppose we giving, means also it will irritate and it will damage the tissue and the poor absorption also will occur. Then procedure, as like every procedure, we need to explain about the procedure to the patient and the family, because first of all we see one patient in palliative care, means if we suppose we are planning to give by subcutaneous, means the totally is a new knowledge for the patient and the family. As a part of the curative treatment side, already they went to another hospital. During the treatment period, they are all practicing so many intravenous or intramuscular route of administration of medication throughout their curative treatment phase. But in palliative care, they are first of all practicing these type of injections and these type of infusions by subcutaneously. So we need to explain about the procedure and about what going to do, going to continue by subcutaneously, everything we need to explain. Then as like every procedure, wash hands, then arrange everything about selected fluid and the tubings, any PMO line or prime line, if he selecting means that thing, that fluid or medication, everything we need to keep it ready. Then we choose the area. If suppose lateral aspect of thigh region is we choosing means after choosing the area, after finalizing the spot where we need to prick, after the complete selection, then we need to clean the area as like circular motion from center to outward. Pricking area is the center. From the center to outward, circular manner we need to clean by using antiseptic solution soaked swab and then leave to dry around 3 to 5 seconds. Just leave for drying. After cleaning, during the period for the drying, never touch again with our fingers on that area. Then we mainly we using the scan vein set or SV set or otherwise butterfly cannula. We mainly using for as a subcutaneous cannula. So after drying everything, that chosen area, we will prick the SV set by using the SV set 30 to 45 degree of angle. That angle we will maintain by while pricking on that area. Then insert the needle. While pricking time, the bevel region of the needle tip. Bevel region means in every needle tip we can see on cross section like on area. That area is the bevel region. That bevel upside on we need to maintain while pricking by keeping the angle of 30 to 45 degree. Then after inserting fully the needle into the subcutaneous space, then we need to secure the needle or otherwise the SV set with anti-tubing with adequate dressing. Mainly we using the micropore or any adhesive material we can use for the fixing the SV set on the area. Then according to the prescribed order we getting from the doctor, we need to adjust the fluid drip or infusion rate we need to maintain for giving the subcutaneous injection or infusion. Video we can see at last. Then we can move to the volume and rate. In
Then I will share the video now.
okay, okay, sir. Thank you.
Sajan, you're muted, I think.
Yes.
Can you please unmute?
We can't hear you. Sajan?
Okay. Can you hear me?
Yes, yes.
Yes.
Okay, thank you. We can just move to the about the volume and rate. So by subcutaneously, if we giving the injection or infusion means 1 ml per minute or 20 drops per minute, that rate we need to maintain. Or otherwise, if that rate is increasing means it will cause the tissue irritation and the pain also will feel for the patient on that area. Then in initial slide only I already told maximum 3 liter of fluid we can give within 1 day or within 24 hours. Now we can discuss in detail. In one side, if we are giving means 1.5 liter or 3 pint of fluid we can give in one side maximum within 24 hours or within 1 day. In again one more side we choosing means second side again 1.5 liter. Like that total in both sides, two sides maximum 3 liter or 6 pint of fluid we can give by subcutaneously maximum within 24 hours or within 1 day. These are all the volume and rate I am telling. But in end of life stage or in palliative care patients, there is this much a 3 liter or 6 pint of fluid is not at all necessary. But these are all we can give is the maximum value. Then, as like the procedure, we explained about the procedure to the patient. We did the procedure. Then, after the procedure, also we need to do something. After getting the prescription from the doctor only, as per the advised rate and volume we already set by after starting the infusion. Then, after starting the infusion by subcutaneously, within 2 hours, don't cross 1 liter. 1 liter volume of medicine we cannot cross within 2 hours. Then, after starting the infusion or injection by subcutaneously, we need to document also about the medicine or about the infusion fluid in the medication chart. We need to mark it. Then check the patient after starting of 1 hour. 1 hour later, after starting the subcutaneous infusion or injection, we need to check the patient. Check the area also. There is any edema or any leakage, anything is there or not. We need to assess the area also. If first of all, while we explaining about the procedure to the patient and the family, first of all, we need to explain us in subcutaneous injection or subcutaneous infusion we giving means on that area, that upper area of the subcutaneous site, there is mild edema is normal only. Because here there is no involvement directly in the circulatory system. Tissue only, we injecting the medicine to the tissue. In the tissue, it will store, and from the storage, it will release. It will absorb slowly. So there is a mild edema is normal for the subcutaneous injection site. But the edema is not at all subsiding, or that edema level is increasing means by a small mild gentle massage we can give on that area. Simple massage only we can give on that area for the easily absorption. If again the edema is not at all subsiding there, it's already the more edema will becoming more means we need to change the area. So we need to assess in between the subcutaneous site. Then advantages about the subcutaneous injection or subcutaneous infusion. First of all, it's already I told scalp vein set or SV set only we using for giving the subcutaneous injection or subcutaneous infusion. So the SV set is comparatively low cost than an IV cannula. On IV cannula means its cost maybe it more than 75, 100 like that. But SV set is much more cheaper than the IV cannula. Then administration also, IV administration is little bit irritating only. More comfortable is the subcutaneous administration. Is both the for the patient also. Then there is no involvement of the subcutaneous route with the circulatory system. Directly there is no involvement in the circulatory system. So, as like happening in the IV administration, like pulmonary edema or any fluid overload is happening, mainly the complication may be happening in the IV administration. That type of complications, there is no chance in the subcutaneous route of administration. Less chance, less irritating and less chance is there also in the subcutaneous route comparatively with the IV. Then simple insertion also. Means if on IV cannula we are doing for a patient means what are all the process we will do for succeeding on IV cannulation for a patient. After selecting the area, we will tie the area with the tourniquet or with the support of our co-worker. We need to tightly handle that area, tighten the area for getting the patterns about the IV site. Then only we can prick by using the IV cannula. In between, if the patient is suddenly pulling back, means cannula will out. Again, that process, again, we need to continue, mainly in the IV cannulation process. But in subcutaneous side means there is no need these much steps of painful steps we don't want for the subcutaneous insertion. So the reinsertion also, and first of all insertion also, very much simple in the subcutaneous insertion comparatively with the IV. These are all the main advantages for the subcutaneous injection or subcutaneous infusion. There, one more point is there, less supervision only needed, mainly for the subcutaneous injection, subcutaneous insertion. If IV cannulation means that much experienced staff only can do, or otherwise one supervision is also needed for getting succeed in the IV cannulation. But in subcu, there is no supervision. Even the caregiver, patient caregiver also can start and practice the IV, subcutaneous insertion. We can educate them also. Then it's not at all cause any thrombophlebitis, like mainly happening in the IV cannulation. In subcutaneous, there is no chance for thrombophlebitis. Then any systemic infection or any septicemia may have the chance, may will happen in the IV cannulation or IV administration of medication type. That type of complications like septicemia and systemic infection, there is no chance in the subcutaneous administration of medication. Then there is if suppose the area having any inflammation or infection is happening means also that area only will affect about the infectious side or any inflammation. There is no chance involving in the circulatory system, and it will never cause the like systemic infection, the septicemia. Then if one IV cannula we put on patient and we given on bolus injection in today morning, example I am telling, today morning we given one bolus of injection, there is no need to continue anything that in that IV cannula. Maybe next dose we need to give at night time or otherwise next day morning. Maybe that cannula becoming blocked due to the clot formation. But in subcu, there is no circulatory involvement, so there is no clot formation also. At any time, we can give the bolus injection. For a daytime, we can't. If there is no need to continue an injection, means we can keep it there only. And at any time, we can restart the injection or infusion in the same subcu site. So these are all the main advantages in the subcutaneous injection or subcutaneous administration. Then some disadvantages also, some minute disadvantages also. Maybe the area if may will happen the possible irritation or inflammation site, that infusion site may will happen inflammation signs or any irritation. Patient also will feel as like pain or any irritation. Then if the tissue having poor absorption power means it will cause the possibility of leakage. After already I told mild edema is normal only. After some time it will subside naturally. But if the tissue is in poor absorption stage means that collection of fluid or collection of medicine around that same area and it will leak out or ooze out. So it may will happen. Or any allergic reaction. It's also very rare only. Allergic reaction means in some patients may will that adhesive tape or micropore is allergic to the patient means for while fixing we will stick on by using that adhesive tape. If it allergic means it will cause the allergy reaction on the area. So it will commonly cause in the subcutaneous area. So these are all the main disadvantages. Then these are all the side effects or complications can occur by subcutaneously while we administering. First of all, localized edema. Already I told mild edema is normal only, but the edema around the site, insertion site already it's having mild is normal, but it's not at all subsiding or edema is increasing means we can solve that problem by giving a spontaneously gentle mild massage we can give and we can settle that issue. Then cellulitis or inflammation. Already I told after selecting the area we need to clean the area by using antiseptic solution soap, the swab as like circular manner. After cleaning, never touch again on the cleaned area with our fingers. That sterile technique we need to do, and we need to continue during the insertion period. If poor aseptic technique is practicing, means it will cause the inflammation and the cellulitis for the patient on that area. So we need to be careful on while doing the procedure. Then if the patient is saying any pain or discomfort or any irritation, if the patient is reporting on the insertion site or upward region of the insertion site, means it is rare only, but if the rate is not at all maintaining as like 1 ml per minute or 20 drops per minute, the rate we not at all maintaining means it will cause the pain and discomfort. So we need to check about the rate and the volume. Then if it need means we need to reduce the rate, or we need to be ensured about the rate and the volume. If the issue is not at all resolving after maintaining, after ensuring about the rate and the volume, again the patient is telling about the pain and discomfort, means we need to change the site. We need to select another site and continue the medication. Then if first of all, I told there is no involvement of the circulatory system and the subcutaneous tissue directly. So while we pricking and keeping the needle inside the subcutaneous site, means there is no chance for puncturing any blood vessel. No chance is there. But in rare cases, after fixing the needle inside the subcutaneous site, if the patient is walking in between or going to bathroom at anywhere, patient is walking in between, roaming at anywhere, accidentally that region is accidentally hit on any door side or corner side or wall side, and will prick indirectly the minute capillaries. It will cause the blood, seeing of blood content or blood tinged fluid we can see in the inside the tubing. Like that, anything we see means it's very rare only. If it happening means we can't continue in same site. Suddenly we need to remove and we need to change the site. And another site we need to select and continue. Then any hematoma around the insertion site we see is there or not, we need to check it. It mainly causing if the patient is having low platelet level, or the patient is already is under the anticoagulant therapy, means there is a chance for seeing a hematoma formation around the insertion site. It's also very rare only. If it happens, means that reason is this only. Then infusion device occlusion in between, example, if a syringe driver or a syringe pump we using, in between the alarm is we hearing, in between the stopping is happening, means it's also very rare only. It's happening means that connection tubing, that prime line, everything we need to check. Any kingling is there in external tubing, means we need to correct it and we can continue. Then as a nurse, after explaining about the procedure, we did the procedure. After the procedure, we know what are the things we need to assess. Everything we know. Then as a nurse, what are our responsibilities? First of all, after starting the subcutaneous infusion, after completion of first hour, 1 hour, we need to check the area. Then another checking, we need to do the inspection every 4th hourly. Every 4 hourly, we need to inspect the subcutaneous site. If there is any tenderness or any hardness is there or not, we need to check. Then any hematoma presence is there or not, we need to check. Then insertion site, poor absorption means there will happen about the leakage. That leakage is there means also we need to check. If we not at all checking about the leakage means we administering medicines will leak out, adequate dose of medicine or infusion will not get to the patient. So we need to check. Then any local tissue irritation, patient is saying or not, we need to check. Then any redness, erythema formation around the site, insertion site is there or not, you need to check. Then already I told any blood content or blood tinged fluid presence inside the tubing is there or not, we need to check. Then any displacement of the cannula. Already I told by sub-Q insertion only patient is actively or patient is just doing adequate daily living activity. Minimally also patient is doing as a part of the daily living activity. Patient is walking here and there, doing some activities. Accidentally, the sub-Q cannula is displaced or it's accidentally unknowingly pulled out. Then we cannot reinsert the same SV set on that area. We need to change. Another area we need to select and we can continue the medicine. So these are all the things we need to check every 4th hourly. Then by subcutaneously, already I told small bolus type of injections we can give by subcutaneously. Then as like drip infusion also we can give by subcutaneously. Then continuous any medication, pain medications, or for making the comfort, any sedatives, anything. We need to continue that type of medicines continuously in a already set dose for a patient. Means also we can continue by subcutaneously by using the equipment syringe driver. Syringe driver, just I am introducing only. Syringe driver actually this one is a small device only. Battery by we can run this instrument by using the battery. It's a mini portable as like syringe pump only. Syringe pump we need to set in a stand and we need to make immobilize the patient in a bed. But if we using the syringe driver means patient actively can do his or her activity by using this with the syringe driver. So the syringe driver is a small portable battery driver as like infusion pump used to give medication intravenously also we can give, subcutaneously also we can give by syringe driver. So mainly the syringe driver 24-hour syringe driver and means per 24-hour and per 1 hour syringe driver also it's available. In our setting we commonly using per hour setting syringe driver. Commonly we practicing. We have both, but commonly we using per hour setting syringe driver. By using that type of per hour setting syringe driver, maximum 24-hour we can give the infusion. But per 24-hour setting syringe driver means minimum 24-hour to maximum 24-hour, 48-hour, 72-hour, as like the hour or days, some more 2, 3, 4 days we can give the infusions by using these type of 24-hour syringe driver. So this one is a demo picture of the syringe driver. So in this syringe driver, some of the limitations are there in syringe driver. In syringe driver, maximum we can use 10 ml of syringe only. In infusion pump or syringe pump means we can use 20 ml, 50 ml like that syringes. But here only 10 ml syringe only we can give in this syringe driver. This one is the limitation. Then here this syringe driver having only the start button. This one is the diagrammatic representation of the syringe driver. In the syringe driver, it's a millimeter scale is there as like after getting the order from the doctor as like mg form. From mg form we need to convert it into the ml form. From ml form to form, millimeter form we need to calculate. Then as like form only we need to set in the syringe driver for getting the medicine through 24 hour or 12 hour according to the doctor's order. Actually, I am just introduced only about the syringe driver. Any doubts you are having means you can ask.
Thank you, Sajan, for the excellent session. Anybody have any questions regarding this topic, please ask. Sajan, chat, one question is there, only normal saline can be given subcutaneous.
Yes. Yes, here subcutaneously, if on drip, if I am telling drip type of infusion we giving means, we can give 0.45% to 0.9% of normal saline. That means normal, NS. NS only we can give by subcutaneously. We practice it like that. But in US, there is a talk like that. They are practicing DNS also. We can give by subcutaneously. But in our setting, we practicing only the normal saline by subcutaneously. Then another question also, how it possible 1 to 1.5 liter by subcutaneously? Already I told bolus type of medication means that rate is 1 ml per minute. Infusion as like drip we are giving means maximum 20 drops per minute. That rate we supposed to maintain means we can give that 1 to 1.5 liter maximum within 24 hours. That rate we need to maintain. Within 1 minute, 20 drops of fluid is getting to the subcutaneous tissue means that tissue, that subcutaneous tissue is capable, it can able to accept, absorb, receive that type of, that 20 drops of medication. And another 1 minute, again 20 minutes. Like that rate we are maintaining means that tissue is capable to accept and absorb the medicines or fluid.
I would like a few things along with Sajan's point. Here only that Sister Alpin was asking only normal saline can be given subcutaneous. Usually a normal saline is the best fluid to give through subcutaneous. But DNS and ringer lactase can also given. There are a lot of literature that is also you can given through subcutaneously, but most the common and safest the IV fluid, intravenous fluid is normal saline. And another question, Sajan told we can give 1 to 1.5 liter in one site for 24 hours. We can give, and also he told that 20 drops per minute we can give. Definitely, we were giving the subcutaneous infusion lot of patients here. So most of our patients are getting fluids through subcutaneously and injections also through subcutaneously, but we don't get any inflammation or anything. Small swelling will be there, but gradually that will subside. There is no complication and no issues so far be noticed. So if you want, I will share some literature about subcutaneous infusion. And another question, how the fluid will get absorbed like osmosis and diffusion. What do you think? Others, please respond. So here, the subcutaneous space to the systemic circulation, no? So which one is the lowest concentration area? So I would like to expect your answers also. I am expecting. So what is the mechanism of action here? So I would like to hear from you all. And also one more question, Sajan. Do we need to withdraw the syringe before starting the subcutaneous administration?
Okay, there is already in videos, you could see while before inserting the butterfly cannula or SV set on the selected subcutaneous site, we need to fill the connected tubing with that fluid. Already I told there is no involvement in the circulatory system, so we can't withdraw the blood or withdraw anything or serum, anything we can't withdraw after inserting in the subcutaneous space. So before inserting the subcutaneous site, we need to fill the connected tubing with adequate fluid. Then only we need to insert. Or otherwise, their air entry will happen. Air will enter first into the subcutaneous space, then the medicine will enter. So that thing we need to ensure.
So any other questions? Please put your answers. Are you there?
If you are having another question, there is no question means I need to ask another question. In between the video, we did on marking us like date and time, the labeling of date and time on the subcutaneous site. That part in between the video you already seen. So my question is, up to how much days we can keep on subcutaneous site? Your idea you can share. For how many days we can keep on subcutaneous site?
Maybe 1 day or 24 hours.
Okay, any other?
So 2 days.
Maybe 3 to 4 days.
Okay. Okay. Okay, so many answers. We got 2 days, 7 days, 24 hour, 1 day, till get blocked. Okay, thank you for your reply. So literature telling us on subcutaneous site we can keep up to maximum 5 to 7 days we can keep. But we need to check every 4 hourly. As a nurse, we need to check the area. What are all the things we need to address while inspecting the area? Already I discussed. That type of complications, anything, redness, swelling, irritation, any presence of blood content in the tubing or leakage, any inflammation sign, hardness, anything we feel means we need to change the site. Otherwise, we can keep it in same site maximum up to 5 to 7 days.
Any other questions? Till now, I didn't get any answers from you. Can you hear me? Please switch on your video. I want to see you all. Very good. So, one question is there, how the fluid will get absorbed. like osmosis and diffusion? That is the question. Okay. Here, the subcutaneous space is the lower concentration area and go to the systemic part now. From the lower concentration to the higher concentration, diffusion. Okay, diffusion and perfusion is happening there. Not osmosis. Here is a diffusion process. Any other questions?
You see any complications?
If we see any complications, can we do normal saline dressing? So far, we don't have any experience of, for subcutaneous infusion, any complications. Sometimes redness will be there. That time, we used to change the needle site. And after 2 to 3 days, the red color will subside. If there is any signs and symptoms of infection, then you can give some antibiotics. Otherwise, you can leave it. Anything you want to add, Sajan?
No, sister. Same only.
So I welcome you all for one day to visit our center for seeing subcutaneous infusion and all. If possible, please come to Trivandrum.
We in the
Do we apply any cream in the infection site? No, nothing. If there is an infection, especially the needle site infection, only redness we can see. Sometimes the patients will say like some pain will be there, very rarely itching, and sometimes numbness will be there. Small, like signs and symptoms of inflammation will be there. If you noticed, if there is if you want to give some antibiotics, definitely give some antibiotics for that. Otherwise, this is one of the good way to give intravenous infusion, especially terminally ill patients and those who are not able to swallow properly and intestinal obstruction. These all type of patients, just imagine how can they get fluid. Sometimes if they have a head and neck cancers, they are even we are not able to put our eyes tube also. So that time we need to give some fluids. So after chemotherapy, definitely the veins also thrombosed. That time you won't get any intravenous line. So that time you can use this way to give some fluids. So I think today also we don't have any case presentation. So this is the first time we don't get any case presentation because lot of sessions we missed a case presentation. If you bring a patient story like intestinal obstruction or head and neck cancers, so we will discuss. So that will get that benefited you also, because after the theory session, if we discuss a patient story like the patient, the session related patient story, definitely you will get more idea. That is why we used to tell, bring a patient story, bring a patient story. So we all nurses, you were not getting any patients for case presentation. I don't believe you are not getting the patients. You will get, if you, please do one thing, if you get a patient, if you are able to write down the patient story, please send to us. Then we will make a presentation and send to you if you are not able to do the PPT. So that part we will do it. So if we bring a patient story, definitely that will help to you. That part you have to understand. And if you don't have any questions, I would like to highlight few things before wind up the session. We have heard a lot of things. We learned a lot of things from today's session, especially Sajan. So explained very very simple language, because you all are nurses. You will definitely from his class you will understand about subcutaneous infusion. Here you have to understand that most of the medications can be able to give through subcutaneous. So that is the important part you have to do. Okay. So here, if the patient is having the patient in an end of life care situation, most of the patient is having restlessness. The patients will become restless. So that time we will give midazolam. That time, if the patient is having pain, we will give morphine. So these kind of medications we can able to give subcutaneously. And also sometimes delirium will be there. If there is a terminal delirium, we can't reverse. So that time we need to give haloperidol. That medication is also given through subcutaneous. So these all things you have to keep it in mind, and also death rattle. So death rattle is one of the most common problem. It will be distressing to the family members. So that time we will give glycopyrrolate. That medication also we can give subcutaneously. So these kind of medications, our aim is to improve, reduce the symptoms. If we reduce the symptoms, we can able to give a in terminal patients. We can able to give a peaceful death to the patient. If the patient is not in the terminal situations, we can able to improve the quality of life through reduction of the signs and symptoms, or reduction of the pain and other symptoms. So you have to keep it in mind. Most of the medications can be able to give through subcutaneously, and very rare side effects will be there, so that we can manage. Okay, and also if you give subcutaneous, if you plan to choose subcutaneous route, definitely you have to tell the patient and the family about it. How there is no swelling. But if you give fluid through subcutaneously, there is a small swelling will be there. So that time they will be anxious. Okay. So before starting subcutaneous infusion, you have to tell them there will be small swelling will be there, that will subside immediately. So maybe within an hour that swelling will subside. So that time they can also understand. That is the important message you have to tell them. Okay. So all other points Sajan has covered well. You all, I hope you all understand well. Sajan, can I wind up?
Yes, sir.
Okay, so we can wind up the session. So especially, thank you, Sajan, for the excellent session. Thank you others for your contributions and joining today's session. Thank you once again. We will see you in the next time. Thank you.
Thank you, Mr. Sajan and Shiva ma'am. Thank you everyone for joining us. This is Anup signing off from this session. Thank you. Bye.